common question we receive in clinic is that what are the pros and cons of these therapies, right? How do you choose between CAR T or bispecific for a patient? My answer to that it's very individualized. Like you have to look at the overall health of a patient, age of a patient, performance status, how fast is their disease progressing, what is the molecular characteristic of their disease. But keeping all that tailoring aside, there are some pros and cons that stand out, which I've summarized here. So if you look at a CAR T cell, the pros is that once the CAR T is infused into the patient, we don't follow up with any medication. In fact, patients are off treatment as long as they're responding very well to CAR T treatment. So it's considered as a one-time treatment. As was mentioned previously, multiple myeloma is an incurable disease, and the standard of care has been to keep giving patients treatment so that we keep their myeloma in check. It's for the first time that we now have a therapy that we give once, and if a patient's responding well, we don't follow up with any therapy. So that is a paradigm-breaking treatment that we have for patients. And by the time patients come to CAR T, they have been on therapy for like multiple years, and they're often eager to have some kind of a break from not getting treatment. So a lot of patients, when eligible, prefer CAR T. These CAR T cells provide durable remissions of therapy, as I was mentioning, and we also see very early immunologic response, and patients stay in remission for a long period of time. What are the cons, though, of CAR T cell therapy? Is everyone eligible? Sadly, no. There is a long manufacturing time that is required for CAR Ts, which are now being researched upon to try to bring down the manufacturing time. But as of today, the manufacturing time ranges anywhere between 2.5 to 4 weeks. So that's from the time of collection of the white blood cell, when it goes to the lab and we get it back to give it to the patient, there is at least a 4-week gap, during which time the patient's myeloma may progress, and we have to give what is called a bridging therapy. So for a patient who's progressing very, very rapidly, CAR T cells may not be a good option. CAR T cells are, in addition to being expensive, it requires a lot of expertise and a lot of training to be given. So therefore, CAR Ts are right now only available at tertiary care centers. So patients who do not have access to tertiary care centers or who live quite far away are often disadvantaged in being able to receive it in a timely manner. Because of the requirement for conditioning chemotherapy prior to the administration of CAR T, there is a specific requirement of a patient having at least a good performance status, meaning you're able to perform your activities of daily living, take care of yourself, bathe, do certain daily tasks like cooking and cleaning yourself. You need to have that certain performance status to be eligible for CAR T, and need to have an adequate organ function. There should be an adequate amount of red blood cells, white blood cells, platelets, kidney function, liver function, etc., to be able to tolerate the chemo before getting the CAR T therapy. So these are the cons, but again, if none of these cons apply to patients, it's an excellent therapy which we recommend to patients. Now, with 3 different bispecific antibodies that are now being approved, they are also gaining more mainstream use. And the advantages that bispecific antibodies have over CAR T cells is that bispecifics are immediately available. You don't need to manufacture them by harvesting a patient's own T cells and processing them in a lab, etc. It's manufactured by a pharmaceutical company, so it's immediately available in what we call as off-the-shelf therapy. These also provide very durable remissions. However, patients have to be on treatment for the longest time possible. And because these therapies are not intricate, they can be given in smaller centers as well. So that, I think, is a big advantage, because patients who are living farther away, they have access to cancer centers that are not tertiary care, but still pretty good cancer centers. They can still get bispecific antibodies as a very effective means for their myeloma. Additionally, because there is no conditioning chemotherapy that we need to give before bispecific antibodies, it can be considered to be given in a slightly older and a slightly more frail population than CAR Ts. So these are all the advantages of bispecifics. What are the disadvantages, though? Quite unlike CAR T, bispecific antibodies need to be given continuously. We start at a lower dose, we come to the full dose, and then dose it in a traditional manner by giving it a weekly or every 2 weeks dosing, and then we space it out to an every monthly dosing until the patient progresses. So if a patient's having an excellent response on bispecific antibodies, let's say their myeloma completely goes away, you still have to be on that monthly infusion because that's the way the FDA approval has worked so far. There are clinical trials that are looking at safe discontinuation, but right now the standard practice is you have to be on treatment. So unlike CAR-T, which is a one and done treatment, bispecific antibodies, you keep receiving it every month until progression happens.